Yes, welcome to the presentation of today. As per the title, today we are talking about schizophrenia. Talking about schizophrenia. A minute, let me set up things so that we cannot hang around. Schizophrenia. We need to define what is schizophrenia and get to understand why people get schizophrenia. So today's topic. Um, let's see here. Okay. Something is wrong somewhere. Let me get to see what is happening. Are you sure? Now let's go on schizophrenia. What is schizophrenia? Schizophrenia. What is what is happening? What is happening here? Okay. Yes, we are back. I think there are some complications and errors that are coming up, but it's being sorted. My crew is sorting out. Coming up, but it's being sorted. Yes, we go on. We're talking about schizophrenia, and we would like to know what is schizophrenia? What is schizophrenia? Everybody talks about someone was diagnosed with schizophrenia, and we will love to understand how does the diagnosis of schizophrenia comes about. I will pin my um, question at yahoo.com. This is for the people who have questions that they have private questions that they would like to, to ask. That's the email address that they can use it to send their questions and requests. We have really talked a lot about uh, health issues, and health issues, most of them, you see, mental issues comes right from the brain. Physical and emotional, psychological issues, they always affect us. And that's why when we started the topic, we started talking by going back to the brain physiology and the anatomy of the brain. Because most mental issues that you've seen, we have come from very far, and these issues are affecting the brain and the capacity of the brain. So when we are talking about mental issues, we are deeply talking about mental disorders, both physical, emotional, and psychological. So today's topic, as you can see, it is schizophrenia. Schizophrenia. Schizophrenia is a topic that everyone has been talking about, and it is being confused by other spectrum of diseases and psychotic disorders. You see that it is being confused by other spectrum of psychotic disorders, because when someone at times presents with a particular thing or a particular case in a particular way, you will find that this person presents psychotic issues, and it is confused by whatever that we are going to learn. So we go slowly by slowly. We learn this topic so that when you diagnose someone, you don't confuse it with something else. You've seen even bipolar disorders, our last topic. There are so many issues concerning bipolar disorders, and people are confusing bipolar disorders by other issues that are not bipolar disorders. So today we do schizophrenia. What is schizophrenia? We do the diagnosis, how to handle it, how to manage schizophrenia, and we go on. We go on to know how to differentiate again uh, between this complication and other complications that come uh, of of any mental issues. So if a person asks you, what is your diagnosis as a mental practitioner, or you've just come out from a doctor's office and you are diagnosed with schizophrenia, what will you tell someone diagnosed with this? So you will tell this person this way. Schizophrenia is a chronic and severe mental disorder that affects how a person thinks, feels, and behaves. You see, schizophrenia is a chronic and severe mental disorder that affects how a person thinks, feels, and behaves. People with schizophrenia may seem like they have lost touch to the reality. Sometimes when you are affected mentally on how you think and how you feel and behave, people may think you have lost touch with reality. It starts in the late adolescence and early adulthood and requires long-term treatment. You get it? So we need to know the common symptoms in schizophrenia. Then we'll come slowly by slowly discussing about the types of schizophrenia. You see, so that we can understand that schizophrenia can be managed. But you've seen we have said it requires long-term medication. Hmm? There are even types of schizophrenia that we will go down and see how to handle these types. You see, like paranoid schizophrenia, the paranoid measures, diagnosed hyperphrenic schizophrenia. We will learn about it, and differentiated schizophrenia, residual schizophrenia, simple schizophrenia. We will see how to manage all these categories of schizophrenia and know how to categorize them. Now, you understand when we are talking about this topic, it's not good to call someone's is nuts. Hmm? Don't say this person is not, it's nuts. Yes, because it's a condition. So um, let's get and see first. We start by the pathophysiology, the how does schizophrenia come about? Hmm? How does schizophrenia come about? What brings schizophrenia? You get it? What brings? Schizophrenia is neurodevelopmental disorder with a complex interplay of genetic, mm, neurochemical structure, and environmental factors. Yes, but when we talk about neuro, you always understand we are talking about the brain. Eh? Neuro. You see, neuro, we always understand we're talking about the brain and the the brain and the the connecting structures of the brain. Mm? And let me say neurotransmitters, the chemicals that we have talked about. That is where we talk about it. So a minute. What? Let me answer this. This one is a private one. Just a minute. What is Yes, we were talking about the term neuro. Now, neuro is a term used to talk about a nerve, a nerve. So nerves have neurotransmitters. You understand the ones we talked about, the norepinephrine, adrenaline. All those are neurotransmitters. So we are defining the pathophysiology of neuro schizophrenia. Now, schizophrenia is a developmental disorder with a complex interplay of genetic, neurochemical, structure, and environmental factors. Its exact cause remain unknown, but several well-supported hypotheses explain the biology mechanism behind its support symptoms. Sorry. Now, we listen to this. We listen very careful and slowly. Schizophrenia is a neurodevelopment disorder with a complex interplay of genetic, neurochemical, structural, and environmental factors. Mhm. Its exact cause remains unknown, but well supported hypotheses biological mechanisms behind it are supported. Now, the first one, let me list the supportive measures that are the hypothesis supportive measures. Neurotransmitter hypothesis, glutamate hypothesis, serotonin hypothesis. You see, we are still talking about serotonin. Structure of the brain, neurodevelopment theory, genetic factors, immune and inflammatory hypothesis. We let's go to we are still defining what is schizophrenia and the supportive measures. We are defining what is schizophrenia and what causes. Now, the pathophysiology remains unknown, but these are the supportive hypotheses that are come. We sit down and look and we see this can be the cause. Dopamine hypothesis, most classic dopamine hypothesis. Schizophrenia results from dopamine dysregulation. You see, dopamine is mesolimbic pathway. Dopamine in mesolimbic pathway. Hmm? There is a pathway that dopamine is supposed to regulate. But when it's not regulating well, you will find a problem by the way you are behaving, your character. Because you see, we talked about it. So, mesolimbic pathway is one of the major dopaminergic pathways in the brain. It plays key role in reward, motivation, and pleasure, most important in schizophrenia. The development of positive symptoms of schizophrenia. Anatomy of mesolimbic, what is the anatomy? Eh? Now, origin is ventral tract, mental area located midway in the brain. There is an area where dopamine is regulated. And here, you see, there are some components like the nuclear accumbens, the amygdala. We have always talked about amygdala and emotions. Core of reward system is the nuclear accumbens. And then hippocampus. Hippocampus is memory. You remember we said in the brain, the hippocampus is responsible for memory. Prefrontal cortex. Before the frontal cortex, decision making, how you make decisions. You see, anatomy, this is now the anatomy of the mesolimbic pathway. Function of dopamine, where in this pathway mediates rewards, pleasure, and reinforcement, activated in response to food, sex, and drugs. You get it? Involved in learning and memory of reward cues, encourages goal direct behavior. Hmm? And then you see there are some things in if this pathway is dysregulated, you will find a positive character of hallucination, delusions, disorganized thoughts or behaviors. Now, you see, it's a complex uh, thing when it comes to regulation of dopamine, because mesolimbic pathway is mesolimbic pathway and the neurotransmitter hypothesis is one of the problems that come out and shows there is a problem. It shows positive signs like hallucinations, hmm, hallucinations, delusions. You see, disorganized thinking and speech. Those are the positive, but they are the positive signs when it comes to schizophrenia. Positive signs, disorganized thoughts and behavior. Now, uh, sometimes people confuse some areas, and I would really like to people to understand uh, some things that are very specific, so that we may not confuse several things as we go on. You see, now we have something called hallucinations. Hallucinations. What are hallucinations? This is in the mesolimbic pathway. This is a positive sign of schizophrenia. So, what is hallucinations? Hallucinations are false sensory perceptions that occur without an external stimuli. There is nothing you have taken, there is no drug or tea or something or any stimulant, but you have false perceptions. Seeing things. This means a person perceives like seeing, hearing, or feeling. Seeing, hearing, or feeling that is actually present in the environment and it's not there. Based on the sensory modality involving auditory hallucination. You see, there is auditory hallucination, visual hallucinations, tactile hallucinations. Now, this I'm going through the positive signs of schizophrenia. We have talked about it of and these ones are the positive signs and under the mesolimbic pathway. Auditory hallucinations, hearing voices, yes. Commenting, conversing, or commanding some things. You've seen some people with schizophrenia doing this. Visual hallucination, seeing people, light, shadow, or objects that are not real. Common in delirium, Lewy body dementia, and substance abuse. Yes, but you see, we have said this can happen even when there is no substance abuse. We go to tactile, tactile hallucinations. Tactile hallucinations, sensations of being touched or something crawling on your skin. You just feel something is crawling on your skin. Olfactory hallucinations, smelling things that are not present, like burning, fizzes. You see, hallucinations. We have so many types of hallucinations. Gustatory, gustatory hallucinations. Tasting something in without any food or drink. You are tasting something sweet and then it's not there. Rare may be seen in seizures disorder or psychosis. Yes. Hypnagogic, hypnopompic hypnopompic and hypnagogic hallucinations occurs while falling asleep like this. While falling asleep or waking up can be normal but associated with narcolepsy. Can be normal but can be associated with narcolepsy. So this is one of the positive sign of hallucination. And you see schizophrenia, mostly you will get auditory, especially auditory, the hearing of voices you'll find. So when you are diagnosing, if you're a doctor or health worker and you are diagnosing on schizophrenia, one of the positive sign is auditory hallucination. In bipolar disorder, this may be there, but minimal. Severe depression, delusion disorders, we talked about them. Okay, let's go to the other one. Let's go to the other one, my friends. Dopamine, mesolimbic pathway, positive hallucination. Now, we are talking about the positive hallucination. Hmm? Yes, the hallucination is one. Delusions. Delusions. These are terms that we really need to know what is being delusional. Hmm? You've heard some songs saying "you delusional, yes. What is delusion? Positive signs when it comes to schizophrenia. We delusions are fixed false beliefs that are not based in reality and are not influenced by logic, reasoning. You get it? Mm? And let me just a minute, just a minute. Someone needs an attention here. Let me work on this faster. Let me work on this faster. Um, hmm. Yes, you see, logic delusions are fixed beliefs that are based in reality are not influenced by logic, reasoning, or evidence to contra, unlike hallucinations. You see, are fixed. You have fixed your beliefs in something that are not reality and are not fixed to hello. Yes, nitakuudini six between and right. You see that that is very important when it comes to delusions. Now we have talked so many things about these mental health issues. So you really need to differentiate what is a delusion, what is an hallucination. So hallucination, we have seen there are several types of hallucinations, and as we have seen, and here it's a delusion. Delusion, it's one. A minute, a minute. Yeah. Today my phone and everything is all over my my everything. Now you need to differentiate these things so that diagnosis and management of a person becomes well. You get it? If you misdiagnose someone, you will forcefully give a drug that is not for the purpose. Hmm? So here we have talked about delusion, and in delusion you have seen, yeah, are fixed false beliefs that are not based in reality and are not influenced by logic, reasoning, or even evidence to contrary, unlike hallucinations. Key features in delusions. You see, there are some key. Sorry. Yeah, I think I'll be putting off my phone before I start this live. There are key features when it comes to delusion so that you can separate between and delusion and hallucination. You see, these are the specific positive features when it comes to schizophrenia. So, what are these key features of delusion? What are these key features of delusion? These key features of delusions are firm held. The person is convinced the belief is true. You have a belief and you believe this belief is very true. You get it? And sometimes not shared. Eh? Not shared by others of similar background or culture. And this person always is really resistant to logic or reasoning, brainwash, and then you become delusional. Some, let me say some not cultures. I'll say some. What do I say? Religions. Yeah, they brainwash people and then they become delusional. You see, yes, very fun, very fun. So be careful when you get to these issues of illusionment. So maybe bizarre, clearly implausible, bizarre feelings or non-bizarre, mm, or non-bizarre. So for the types of delusions we have persecutory, believe that one is being harmed, spied, or plotted against. Grandiose. We talked about grandiose some times ago. Exaggerated sense of power, important, or in identity. Referential. This is types of delusions. This is types of delusions. Referential believe that common things. Yes, beauty. Welcome. Today we are talking about schizophrenia, and we will be talking about several things about delusions that are about schizophrenia, so that you may differentiate between uh, people that are delusional and the people that are. Now we are continuing with our topic. I'm talking about types of delusions. We have nihilistic. Now, in schizophrenia, we have said it is divided into several, but the divisions into several, we have neurotransmitter hypothesis. The neurotransmitters are interfering with something called dopamine in the pathway called mesolimbic pathway. And these things, they bring some positive symptoms. So the positive symptoms are the ones that I'm talking about. Delusional, you are delusional. We have talked about how delusional is. Now we have hallucination. We have talked about how hallucination is, so that you differentiate between a person who is hallucinating and a person who is delusional. Now here we are talking about types of delusions: grandiose, exaggerated sense of power, importance, or identity. I'm the president of the world. You get it? You are delusional because you are not the president. Now, this person is schizophrenia and is delusional. And then we have something called persecutory, the most common. Belief that one is harmed, spied, or plotted against. My neighbors are trying to poison me. You have been around someone who is thinking like, my neighbors are always, this one has gone to black magic or is gone to a witch. This person, you get it? These are persecutory. This person is delusional. Differential. Believe that common things, TV, newspaper, or sending messages directs to person. The news anchor is speaking in code to me. You see, when a person is looking at TV or a newspaper, is thinking this person is code talking to me. Codes. Nihilistic. These are persecutory, grandiose, referential, nihilistic. These are types of delusion. Belief that nihilistic is that belief that the world, body, or self no longer exists. We have. I will not mention some religions, but we know a religion where they believe there is no heaven. Nihilistic. I'm already dead. Yes, a nihilistic person believes in spirits. He believes he's already dead. Even this body is just a chamber walking around. Delusional. We are talking about schizophrenia, and these are the positive signs when it comes to schizophrenia. So know how to differentiate them. We have error. Erotomanic. Erotomanic. Believe the thought of actions are being controlled by outside forces. Just imagine now we are talking things that happen. Yeah? Evelyn Minage, my sister from another mother. If those people that believe whatever is happening in their life is being forced from another planet or someone, some forces somewhere. You get it? We call them somatic, somatic people. So somatic, delusional. Now, today we are talking about a very good topic. This topic is called schizophrenia. Hmm? So we will know how you to differentiate some things that we usually see people go through. So you see, I'm talking about delusions under schizophrenia, and you see, positive side delusion is positive side of schizophrenia. You see, we have said somatic. Somatic is one of it. Please like the video, subscribe as we go on. Hmm? Religion. Let's break our chains from religion, because everything I'm talking about, you hear people saying, yes, erotomanic believes that someone often famous is in love with them. You will find someone always having a picture of someone who is famous. Eh? Erotomatic person. You are delusional, my friend. You are delusional. You are not, no, I'm talking about schizophrenia. Yeah, I'm talking about schizophrenia, but this is one of the topic. This is one of the positive side of schizophrenia. But having one does not mean you are schizophrenic. No, it means you are having a trait. Now we are talking. We go to the control or influence delusion. Believes that thought or actions are being controlled by outside forces. We have talked about that. Thought broadcast believes others can hear one's thoughts. Those people that believe uh, can look at you like this, and believe that I'm hearing your thoughts, or you're looking at someone like this and you feel that that person is feeling that the way I'm thinking. This is delusional, one type of delusion. And then there is the last one, thought insertion. Believes that thoughts are being inserted into one's mind. Imagine. So, positive sign of schizophrenia, we have hallucinations. We have talked about hallucination. We have seen several types of hallucinations, and then we are in delusional. I will go to name them as I go on. We the, we will talk about grandiose type of, yes, it's true, beauty, grandiose. We will talk about referential, we have talked about it, nihilistic, somatic, aromatic, control and influence, thought broadcasting, thought insertion. You get it? This is the types of, I've explained them. This is the types of delusions that we have, and the positive signs of schizophrenia. Remember, we have talked about schizophrenia. Schizophrenia is let a minute. We have said schizophrenia, spectrum, and psychotic disorder are a group of several mental health condition. It's a group of mental health condition characterized by primarily psychosis, which include delusion, hallucination, disorganized thinking. So the types of schizophrenia that we have schizophrenia, which is core. We have schizophreniform disorder. We have belief psychotic disorder. We have schizoaffective disorder. We have delusional disorder. We have substance and medication-induced psychotic disorder. We have psychotic disorder due to another medical condition. We have catatonia and others unspecified schizophrenia spectrum and other psychotic disorders. Those are the ones we have. There are 9. Then we will go to management. Now, we talk about something here which is very important: disorganized thoughts. Disorganized thoughts. How is how do you feel that this person is having disorganized thoughts? Think about it. Disorganized thoughts. Hmm? It is the way a person thinks. Hmm? The way a person thinks. Minute is it's the way a person thinks, the impairment of logic. And no, remember, one day I'll come with a topic called logic. Logic is a very big topic. Is a big topic the way you know. It's not just a word. The way now disorganized thoughts refers to impaired and illogic thinking patterns that affects a person's ability to communicate ideally, clearly, or logically. This is often seen in psychotic and schizophrenia. You get it? Now, we have talked about the three positive signs of schizophrenia. Hallucinations. We have seen types of hallucination. We have gone through delusions. We have seen and discussed about delusions. The third, disorganized thoughts. Now we will go here. The second one. We are at the first one, which is neurotransmitter hypothesis to define schizophrenia. Dopamine in mesocortical pathways, negative symptoms, and cognitive dysfunction. So when a person has negative thoughts and cognitive functions, we talk about mesocortical pathway on the dopamine. And then there is glutamine hypothesis. All these are neurotransmitters of the brain that they get. Mark Brown, the artist, is in the house. Mark Brown, hi, we are talking about psychosis, and we have categorized it. We have talked about the positive side and the negative side. Now we are going to glutamate hypothesis. That one is also a neurotransmitter, glutamate, that is in the brain, that affects how a person thinks. And yes, Mark Brown, I'm good. Let's talk about, if you have a question about this topic, please come on and let's talk about ketamine symptoms. NMD receptors antagonists like ketamine and phenylene produce hallucination and disorganized thinking. So when you go to the theater and then we inject you with some substance, you get hallucinated, you will know that we have interfered with glutamine in your brain. Then serotonin pathway and the structure of the brain. Sometimes when your structure of the brain is destroyed, you may get psychosis or schizophrenia because of the way these neurotransmitters are being released. And then we have neurodevelopmental theory. Schizophrenia may result from abnormal brain development starting in utero, early life. You see, when it's early life, when you are growing up, schizophrenia may start by that time as you grow, because the brain has complications. So obstetric complications, when obstetric we mean when the baby is inside the womb, prenatal infections when a kid is still in the womb, when the baby is still in the womb, childhood trauma or cannabis use in adolescence. Cannabis is bang. So it slows your thinking capacity and release of serotonin. So it may interfere with the way you are thinking and the way you are carrying out things. You get it? The factors which interferes with genetic disposition. And then we have genetic factors. Genetic factors, irritability, 80%, heritability. You inherit a particular symptoms from birth when you are a young person, and then you grow out with these disabilities. You get it? Risk increase with family history of monozygotic twins and first degree relatives. So when you are a twin, you can inherit of the first degree relatives. And then there is immune and inflammatory hypothesis. Immune and inflammatory hypothesis. We have talked about that inflammation is healing problems when you are injured, and you get it. Now we go here. I think we talked about several types of schizophrenia. So the first one we have talked about is schizophrenia, which is the core. At least two of the following or 6 months to identify a person with schizophrenia, you need to have at least two of the things that I'm going to say, or at least 6 months, 6 months of having them, including at least one of the following: delusions, hallucinations, disorganized speech, at least two of the following: grossly disorganized or catatonic behavior. You have a funny behavior. Negative symptom: flat affect, avolition, alogia. You check this out. Yeah, we have started. Let's because someone is asking me about negative symptoms. I've not negative symptoms. Negative symptoms in negative symptoms in schizophrenia. Negative symptoms or losses of normal emotional and behavior function are the most common in schizophrenia. Yeah? Affective. These are the 5S. So when a person tells you about the negative symptoms in schizophrenia, symptoms, we talked about the positive ones. The positives are three in schizophrenia. We talked about delusion. We have seen types of delusions. We have seen the types of delusion. Then we went to hallucinations. We have seen types of hallucinations. And then the third one, disorganized thoughts. Disorganized thoughts. If you are getting to the platform, when you are finished, please start from the beginning. There are several. This is a wide topic. Yes. And then now, when you come to negative thoughts in schizophrenia, you talk about the 5S. 5S. Yeah. Affective flattening, diminished emotional expression, reduced facial uh, expressions, eye contact, voice, and tone. That is the first one, affective flattening. And then we go to alogia. What is alogia? Poverty of speech, brief, empty replies, or long pause before responding. Ati, this is like, let me say this. Hi, what's your name, please? Look, oh, you've asked about my name. I am Benjamin. Okay, where do you come from? Before you answer, you take some time. This is what is called alogia. Alogia, the 5 A's of negative symptoms in schizophrenia. And then we have avolition. Avolition, lack of motivation to initiate and sustain purpose activity. Lack of motivation, e.g., hygiene and work. Avolition. You have seen this to people who use marijuana at times. Marijuana induces psychotic and schizophrenic symptoms, mostly the alogia one. Anhedonia, 5S, affective flattening, alogia, avolition, the other one, anhedonia, and the fifth one, aso, aso, asociality, lack of interest in social. You don't want a social life. You don't want anyone. And then anhedonia, inability to experience pleasure in activity pleasure, find something that was giving you pleasure previously, you don't find it having pleasure nowadays. It has gone. Avolition, lack of interest in sustained purpose activities. You don't feel like hygiene. You don't see the need of hygiene. So this is very clear that in schizophrenia, for you to know this person is schizophrenic, we have said there is positive signs and negative signs. Positive signs, we have talked about three things: hallucination, disillusional, and disorganized thoughts. And then there is the five negative things we need to see when it comes to negative signs. Affective flattering, we have talked about it. Alogia, we have talked about it. Avolition, anhedonia, and asociality. Not this person doesn't think about having a social life. A person is in his own world. Now, when we talked about delusions, you saw it is really coming out clearly about some brainwash and some, so you don't differentiate some people. When a person is brainwashed, you think about the positive sides. When a person is in hygiene and unhygienic, you think about negative signs. Yes. Now we go and talk. We have now, that was a question somebody asked privately. I talk about the negative signs, and we were going to the types of schizophrenia. Types of schizophrenia. The first one, we said at least two of the following include at least one of the first 3 months: delusional, hallucination, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms, the ones that we have talked about, at least two of them, significant functioning decline in work, relationship, or what? Or self-care, usually early early 30s. Onset, early 30s. Why do we say early 30s? Because at 30s, this is where someone is really at his power to make resources and build his life, family life, personal life, that one. And then we go to the second type of schizophrenia. The second type of schizophrenia disorder, same symptoms, schizophrenia, it is called this way. The second type is called schizophreniform. Schizophreniform disorder. Schizophreniform disorder. Same symptoms as schizophrenia, but the duration is short. You get it? The schizophrenia, the first one we have said, you'll be delusional. At least you have to have two of hallucinating, delusions, disorganized speech, grossly disorganized or catatonic speech, and the negative symptoms. You have talked about the negative symptoms: flutter, affect, avoliation, and alogia. You get it. And at times, at the second one, which is schizophreniform, is schizophreniform disorder. At times, it may be short, last more than 1 month, but less than 6 months. More than 1 month, but may or may not progress to schizophrenia. Someone may improve with the time. And then the third one is called brief asymptomatic disorder. Brief asymptomatic disorder. This one is called brief psychotic disorder. Some symptoms of psychotic, asymptomatic, some symptoms of psychosis, some symptoms of a person who you say is nuts. You get sudden onset of at least one positive symptom. Sudden onset of at least one positive symptom: delusions, hallucination, disorganized speech or behavior. You get it? Delusions, hallucination, disorganized speech or behavior. Sudden onset of one positive. This is at time 1 day or less than a month. It goes to at least 1 day or less than 1 month. Then we go to another one, which is schizoaffective disorder. What is schizoaffective disorder? We are going like step by step. What is schizoaffective disorder? Schizoaffective disorder have both features of schizophrenia and mood disorder. We have not really talked about mood disorder, but we will come and talk about it. But it's like mania or depression. You get it? Mood disorder, mania or depression. Key criteria in schizoaffective disorder is this one: Delusions or hallucinations must be present in at least to 2 weeks, hmm, without mood symptoms. At times it doesn't have mood symptoms, it's just like that. Eh? And then you'll get depression or mania. You get it? You'll get depression or mania. Today my phone is up and down. Hey, these people doesn't know I'm live. Now we have talked about up to four, which are schizophrenia, and then we've talked about schizophreniform disorder. We have talked about brief psychotic disorder, and then we have talked about delusional disorder. You get it? Delusional disorder. These people, let me put my phone on air because they are not listening. They are calling and calling and calling. Sorry about that. They are not listening. Yeah. Now we go on, please. We go on to this topic. Now, we have talked about schizoaffective disorder, the features of schizophrenia and mood disorder, depression and mania, at least 2 weeks. And then we go to the delusional disorder. We have talked about being delusional. We have seen presence of one of the delusions disorder, presence of at least one of the delusions disorder. What are these? The ones we have talked about? We have talked about them. We have talked about hallucinations, and then the delusion disorders that we have talked about are uh, fly. Not that one. We have talked about several things. uh, the negative ones are allodonia, voliation, and association. Now, the other one, we will go. Oh, sorry. Let me do this. Mhm. Sorry, just a minute. Schizophrenia, that one. Yes, we are in delusional disorder. Now, presence of one of the delusion, it has to go to at least 1 month. No other prominent psychotic symptom is seen here in number 5, delusion disorder. Types of delusions include grandiose, we have talked about it, aromatic, we have got jealous, persecute. Hey, you see, jealous is here. Jealous. Jealous is a very bad thing. It's a delusion disorder. We have talked about it previously and it's coming out. And then we have somatic and mixed one. These are delusions disorder. Now, what is delusion disorder? We have talked about delusion disorder somewhere, but you see, it's a big topic that we really need to know what delusion disorder is. You get it? Delusion is a psychiatric condition characterized by the presence of more persistent non-bizarre delusions, beliefs that could be convincingly happening in real life, lasting for what? 1 month. They are not happening, but you can convince people they are happening. You see, types of delusion disorder: persecutory, aromatic, jealousy, somatic, mixed, and specified. Now, grandiose is one. Grandiose, belief of having great talent, power, and fame, delusion. And then aromatic, belief that someone is in love with them. We have talked about it. Persecutory, belief that conspired again, of being conspired against, spied or followed. We talked about it. And then we have how can we avoid these problems? Yes, we are coming to that. We are coming to that beauty. We are coming to that. Let's finish the categories, then we go to management. We have unspecified, does not clearly fit anywhere. You are just having several and complications everywhere. You get it? Substance medication induced psychotic disorder. Psychotic symptoms caused by use of intoxication or withdrawals. Common cause stimulants, cannabis, hallucinogens, alcohol, and steroids. You take these things and then they temper with your neurotransmitters in your brain. You start hallucinating. Yes, you start hallucinating and at times producing negative symptoms of psychosis. Hmm? Very bad, very bad, very bad. When you take something and you start hallucinating or become psychotic, it's not good. Just leave that substance. Now, psychotic disorder due to another medical condition. You see, psychotic, we are at number 7 types of schizophrenia. Psychotic symptoms caused directly by neurologic or medical, e.g., epilepsy, brain tumor, HIV, and lupus. Very soon, I'm bringing these topics on. HIV will be coming because it's a mental health state issue that we need to talk about it. HIV and brain tumors, also even lupus. They can interfere with your brain, and then you need to be on some drugs that help you not to interfere with your brain. Number 8 type of schizophrenia is catatonia. Catatonia, specify or independent diagnosis, can occur in schizophrenia or mood disorders. Catatonia, specify or independent diagnosis. So, what do we know about catatonia? This is the 8th type of schizophrenia. The eighth type of schizophrenia. What is catatonia? Catatonia is a psychomotor syndrome characterized by abnormality in movement, behavior, and responsiveness in psychiatry. You see, it is giving you problem in movement or medical condition. Hmm? You see, catatonia. Eh, uh, when someone is schizophrenic, you may find even the movement is affected. I think we are talking about it right now. There are types of catatonia: staparous catatonia, immobility mutism; excited catatonia, hyperactive agitation; malignant catatonia, life-threatening with fever and autonomic instability. Those are the 3 types of catatonia. I'll talk of today. We are talking about schizophrenia. Catatonia is also a big topic. I see we have very many things to talk about. I'll talk about it, but let me just run and rush about the topic, how the catatonia can be. The movement. There is stupor, catalepsy, waxy flexibility, mutism, negativism, posturing, mannerism, stereotype, agitation, grimace, echolia, and endocopraxia. When we will talk about catatonia, I'll go through all those. Now, we go to catatonia can occur in schizophrenia or mood disorder. You get it? Features include motoric immobility, mutism, negativism, waxy flexibility, the ones we've talked about. The way you walk, the way you behave is what we call catatonia. You see, it's the 8th type of schizophrenia diagnosed under schizophrenic disorders. And then there is the last one, which is other type and specified schizophrenic and other psychotic disorders. Used when symptoms don't meet full criteria of being, you can get someone is behaving like a schizophrenic person, and then you 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 are not sure if to categorize this person because the positive signs are low and the negative signs are even lower. So you are not sure. These are unspecified. So we put them under unspecified as for observation. Now, yes, we someone asked um, yeah, about management of schizophrenia. There, when you get someone is having schizophrenia, we have talked the pathophysiology from genetic factors, neurodevelopment factors, the ones that people are born with, structure of the brain, neurotransmitter problems in the brain. You see, and then immune inflammatory in the brain. So steps in management of in management of this patient is very intense. Mm? It's very intense, and we should be very careful because when you don't handle these people very well, these people may injure you, or he or she may injure himself. Yes, as we go on, please like the video, share it out, and then we get more people so that we can help people out there. Yes, yes, yes. Steps in management. In this, we really need to know how to handle these people, because most of the people, when it is too bad, we hospitalize them. First step in management of a person with schizophrenia is recognition and initial assessment. You get it? You check this person. Step one. Step one is recognize the clinical features, the ones that we have gone on, e.g., mutism, stepper, waxy flexibility, the way a person moves, the positive signs that we have said, the negative signs that we have said. And then there is something that the doctors use, the professional use. It is called Bush Francis Catadonia Rating Scale. You get it? When you take this person to hospital, you don't just look at this person and say, this person is schizophrenic or psychotic. No, you have to use some tools. There are tools that we use. They are written down and they are tested and they do work. And you use them to categorize if a person is schizophrenic or this person is psychotic. So the first tool that is being used is that one that is called Bush Francis Catalonia Rating Scale. You see, Bush Francis Catadonia is used to screen, assess, and severity of catatonia in neuro syndromes, in brain syndromes. Then we are still in the first dimension of schizophrenia. Hmm? Schizophrenia is a very deep topic, but I'm brushing up out because I have people that watch this are more of them are not doctors, but doctors even watch, health workers watch. So I want to make it easy for everyone to understand. Now, we have differentiate from similar conditions. Neuroepileptic malignant syndrome, history of antipsychotic use, you should ask. Severe depression with psychomotor retardation, differentiate from this. Locked in syndrome, akinetic mutism, differentiate even from delirium. Those are the things you should differentiate. Recognize, recognition and initial assessment. It is done by a professional, a professional. And then there are some investigations that we do so that we can know if the neurotransmitters in the brain or there is a problem, like full hemogram. It is called complete blood count. Electrolytes imbalance. We check the kidney. Is the electrolyte, liver, and the renal function doing well? Is the calcium okay? Is glucose okay? Because if these things go up, they will interfere with the brain function. There is thyroid function test here. The thyroid, we have talked about the thyroid function so much when it comes to mood. There are several tests and toxicology issues that we do. You may even go and do a CT or an MRI. When a person is schizophrenic or you feel is this, even if you go to a doctor and this doctor doesn't want to do this test, just request the doctor to do, like MRI of the head. Maybe there is something traumatizing in the head, trauma that is happening in the head. And ECG, you see, to exclude non-conclusive status of epilepsy, do an ECG to get away, to know that there is no epilepsy. Because some people that are epileptic, they may come up with a schizophrenia because of neurotransmitters imbalance in the brain. And then there is this thing we call lozapam challenge test. Lozapam. You give lozapam 1 to 2 milligrams IV for some time and then you observe the response. If the patient start walking or moving, strongly supports, because when you give losartan, this person should sleep. But you see, when you are giving it and the patient is standing and starting to walk, we think of catatonia. It's a trait in schizophrenia. These are the things we do. We start testing. We are still in the investigation time. And then we go to step 3, treat underlying cause. Now you have done all those tests. You have checked the brain, you have checked the blood count, you have checked the liver. Is there any raised bilirubin? Yes. Is the liver cell suffering producing bilirubin? You have checked all these things. So you treat the underlying cause of it, because there are some people when they are sick, when these people are undergoing some issues like malaria, bilirubin is high, you may confuse them with being schizophrenic. So what do? You treat malaria and then the effect goes up. So if you find that this person has schizophrenia secondary to something, treat that thing like bipolar mood disorders. Mood stabilizers are okay. When you find someone has bipolar, you give mood stabilizers like benzodiazepines. The drugs that I usually say they are not sold over the counter. You go to your doctor to clarify. Medical uses correct. When you have done and you are treating, if you find electrolyte imbalance, hyponatremia in the kidney is not working well, treat it. Treat infections or responses like encephalitis and meningitis. You see, they can cause psychotic or schizophrenia. Step 4, continue the benzodiazepine therapy like clozapam for at least 14 days. You get it? Monitor for sedation to see if it is working. If symptoms resolve, you remove slowly, 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 because we talked about how benzodiazepine work. And then we go to step 5, electro convulsive therapy. Electroconvulsive therapy. You know how electroconvulsive therapy work. Eh? No response to benzodiazepine, we go to electroconvulsive therapy. We jack the brain so that this the brain function with electrons start working well. There are some times people say that one was taken to electricity. In Kenya and Africa they say it. Huyo alipelekwa kwa electricity kwa stima. That is like he was taken to electricity to boost the brain. Electroconvulsive therapy is a psychiatric treatment which believe electric stimulation of the brain is used to induce control seizures with goal improving mental illnesses. It is safe, very safe, and it helps in long life. You get it? ECT procedure. The procedure goes to 6 to 12 sessions, 2 to 3 times per week when it is a rapid and often dramatic response. You get it? We that one I'll explain slightly. Then we go to step 6, supportive care. Hydration and nutrition very important. Give foods that can increase can increase serotonin in the brain. Prevent complications from morbidity like DVT, regular turning pressure and pressure source. You see, if someone sleeps for so long because of being given some drugs, like let's say like diazepam, this person may bring bed source. It's not good. So you check on him. Physical therapy, monitor vitals. Now, step 7, long-term management. We talked from the start that these are problems that require long-term management. You get it? Long-term management. And now that they require long-term management, what do we do? What do we do? Address long-term ages and by ages schizophrenia. Avoid future psychotic use unless absolutely needed. Don't use antipsychotic for long, but put this person on a clinic somewhere to see a specialist at least once a month or twice. You get it? And this person should be on family health and social health. Very important. There are some drugs that are there for antipsychotics, not antipsychotics, for schizophrenic people. We have seen how the drugs are being given, like clozapam. Lexotanil, and the others. They are mood stabilizers. If you use them, you will be okay. But when we started, you remember I said it is a long-term condition that when you are in this condition, you will be observed and you will have a stable mood. You get it? But the cause is unknown, but the causes that I said, they are hypotheses from the doctors that are believed to be causing these things that I've talked about. You see, we have gone to positive signs of diagnosing schizophrenia and negative signs. Please listen, go back to the video and look at them and see. You just don't call someone this one is schizophrenic, but when this person does not have these signs, you get it. Now, number 7, in long-term management, you have talked about it, and when you really need them, it's an emergency. This is a person who is schizophrenic but is displaying autonomic instability, tachycardia. This person is displaying tachycardia, fever, and BP fluctuations. The BPs are fluctuating. This person needs to go to the hospital. Hyperthermia, hyperthermia, when the temperatures are high. Dehydration, when this person is dehydrated. Malignant catatonia, NMS as speech. Catatonia, we have talked about. Severe malnutrition or immobility, because when a person is schizophrenic, he will not have interest in eating, and people will not, especially those people who live alone. Be careful with them, see them, go see, find them, and look at them how they are. Now, the summary table of management is we will rush through them as we finish. One is recognize and assess symptoms. Two, we have talked about the Losartan challenge. Number 3, identify and treat underlying condition if it is brought by a condition. Continue Losartan if effective. Yes. Use ECT. That is 5th. Provide supportive care from social environment and the people around. Plan for long-term follow-up and presentation. Yes, that is how you should get medication, see your doctor. But most people that are in with schizophrenia, the medications are long-term, because whatever we have seen there, mostly we have seen there are things that are genetic, born with, unknown factors. So we will only manage but don't treat. You have to be visiting doctors and always having those drugs. Hmm? Yes, I wanted today to talk about anxiety disorders. Anxiety disorders, but I'm seeing my time is uh, is down. Anxiety disorders is down. So next time I'll just introduce anxiety disorders, and then we close the day, so that we will continue with it next time with the next topic that we will have next time. Now we will talk. Anxiety disorders are a group of mental health conditions characterized by excessive fear, worry, and related behavior disturbances. You see, while anxiety is not normal stress response, this disorder, it becomes chronic, excessive, and impairs daily function. The core features of anxiety disorders are excessive worry or fear, physical symptom, cognitive symptoms, and behavioral symptoms. Excessive worry or fear is difficult to control. Difficult to control. Physical symptoms are palpitation, sweating, tremors, and restlessness. Cognitive symptoms are racing thoughts, fear of losing control or dying, and then behavioral symptoms are avoidance, hypervigilance. Very nice, very nice. It's a very long topic. I will do it next time. I'll start it and do it next time. So I usually give some 2 minutes for questions. If someone has any question, If someone has any question before I close up the day's topic, we have talked about schizophrenia, and you have seen types of schizophrenia. And even if you don't have a question right now, if you go to through the videos, and then you think about sometimes back for you can always email me. My email, I've pinned it there, and then we know what to do. Mhm. So I think there is no question. I will end the video there. We talk tomorrow. Tomorrow is on Friday. Everyone have a nice day and be blessed. If you don't have any question, be blessed. Let's meet tomorrow.